Hello everyone. Today we will talk about pharmacology and NSAIDs, gout and anemia. There is a lot of high yield topics about NSAIDs, gout and anemia. We are going to talk one by one and we are going to highlight it. All right, so let's start. Okay, so one thing that we need to know is what is the definition of what does it mean NSAIDs. It's no steroidal anti-inflammatory drugs, right? So that means that are not corticoids. So steroids are the cortisol. That is nothing to do with NSAIDs. Just remember, very simple, NSAIDs have three properties: anti-inflammatory, we have analgesic, and antipyretic. These three are all are going to be the common effects or properties of these NSAIDs. We will talk about aspirin, that is an NSAID, but a little bit apart from the rest, because aspirin is like level one. It's like the minor activity for analgesia, for fever, and for inflammation. So that is why we consider NSAIDs like a comparison, like line one. The rest have different characteristics. Now, the aspirin, the difference of the other NSAIDs, and is what is the king or the queen, whatever you want to call the aspirin, is about the clotting. So the aspirin will they're going to last about 7 days. That is NCLEX. So please remember always that. 7 days is the effect of the antithrombotic. So that means that it's going to inhibit the plaquetary aggregation. So more specifically, what is doing all the NSAIDs are inhibit the plaquetary aggregation. But the aspirin is the one who is more remarkable than other NSAIDs. They can last 7 days in the aspirin. In the others, they can last few hours, but no more than 1 day. All right. So aspirin, we need to remember the maximum dose is 4,000 milligrams, and for aspirin, we need to remember a few things. I was reading some questions about NCLEX. Intoxication for aspirin. So tell me, how is going to look, or what signs and symptoms is going to show a patient who has salicylism? Okay, we already know about tinnitus, right? So this is the basic thing. Aspirin intoxication is going to be tinnitus, but what else? So it's going to kill the patient, the aspirin? Absolutely yes. So we have you start nauseous and vomiting, gastrointestinal disorders. You start to have some confusion. Even you can lead into seizures and coma and death. Okay, seizures, coma, and death. Sorry. I'm sorry. Okay, so that is about the NSAID. So one thing about aspirin in addition is the Rey syndrome. Rey syndrome. Rey syndrome. Rey syndrome can kill the patient? Yes, it can kill the patient. And we are going to see that in the next slide. All right, so here, the one I want really to remember is the aspirin. And I didn't put Tylenol or paracetamol or called the acetaminophen. Why? Because acetaminophen Tylenol is not an NSAID, please. This is the very most basic thing about all these analgesics, is that the Tylenol called to paracetamol or Tylenol, that is a commercial name, is not an NSAID. Okay, why? Because Tylenol doesn't have the three properties. Only has for pain and only have for fever. Pain and fever. Pain and fever. That is Tylenol. Okay, so that's why it's not considered an NSAID. All right, so we have NSAIDs. The side effects. Always, all side effects are going to be the GI tract upset. if you remember you need to remember the prostaglandins. The prostaglandins. The prostaglandins, and this is something that you please must remember. Prostaglandins, let me see. Prostaglandins are going to have, I'm sorry, the pen is still not working. It's going to be anti-inflammatory. It's going to be for pain. It's going to be for inflammation. It's going to produce mucus. Okay, and that is going to produce the inhibition of the clotting. Okay. All right. So let me go because it's not working. All right. Okay. All right, so just remember NSAIDs, GI upset, dyspepsia, nauseas, vomiting, check for blood tarry stools. That is basic because NSAIDs, what it's doing is to inhibit the production of mucus. Why? Because it inhibits the prostaglandin. So you must remember the action of prostaglandins. So that can produce bleeding because the acid get close to the in touch to the mucus of the stomach and produce bleeding. All right, so let's keep going. All right, so one thing here is the NSAIDs that produce. They are going to be hepatotoxic. It's going to be hepatotoxic, and nauseous, vomiting, tinnitus, salicylism. Remember the tinnitus. And when a patient is in pain, always you need to remember the patient is going to have a little bit elevation of the blood pressure, are going to increase the pulse, the heart rate, and the respiratory rate. Why? Because you're in pain, right? You're in pain. You are in alert. You are trying to do something alert to prevent that pain, right? So that's why the body is going to release adrenaline, and this adrenaline is adrenergic receptor. So that's why it's going to increase all these blood pressure, especially and the pulse. All right, so here we need to consider vitamin K, for example, vitamin K deficiency. Vitamin K deficiency, what is doing vitamin K? Vitamin K is going to make the clotting process, right, of the coagulation factors, vitamin K. So that is actually the secondary coagulation. The primary coagulation, if you remember, is the platelets. Secondary coagulation will be the coagulation factors. And the coagulation factors, secondary coagulation is led by the vitamin K. And the primary coagulation is for the NSAIDs. So if you give NSAIDs, you're going to inhibit the plaquetary aggregation. And the deficiency of vitamin K is going to make a deficit on the production of fibrin from the other side. So just remember that a clot is equal to, say, red blood cells plus platelets plus fibrin. If one of these two components, the fibrin or the platelets, are not present, that is not a clot. So be careful with the deficiency of vitamin K, and you already know what could be causes of vitamin K deficiency: diet and medication, especially antibiotic or broad spectrum. All right, peptic ulcer disease is contraindicated, of course. Peptic ulcer disease. The peptic ulcer disease is mostly happen in the duodenum, close to the duodenum, in the pyloric area, the antrum. So if you can tell, is by gravity, the gastric acid go to that area. So how soon is going to, you can recognize a peptic ulcer when you eat. You eat right now, and the pain starts in just 5-10 minutes. That means that the ulcer is in the stomach. But if they start about half an hour or more, that means that the ulcer is in the duodenum. So that's why we already remember that the gastric content is going to take about half an hour to 2 hours, and in 2 hours is half an hour starts to pass into the duodenum. Okay, so NSAIDs, we need to prevent. We don't want to wait until the pain appears, because there's a lot of substances that are being released, and the pain, to control that kind of pain, is going to take longer. So it's better to prevent than try to fix it if the pain appears. So you need to remember by clinical history. You need to tell at what time the pain is coming. Oh, I have pain mostly at night, so you need to give late afternoon some painkiller. All right, so if you take NSAIDs for more than 2 weeks, please go to your doctor, because it could be something serious. All right, so we have NSAIDs, we have the diuretics, another high yield for NCLEX. NSAIDs are going to diminish the effect of diuretics. We already talked about anticoagulants and the corticoids. Please, what is coming next class is going to be, we are going to talk about corticoids. So you must know all the activities, all the properties of the corticoids, please, okay? Corticoids have anti-inflammatory, decreasing the immune system, depress the immune system, is going to increase the glucose in blood, is going to have produce osteoporosis, gastritis, lipolysis, so many other situations that are going to need to be considered in the nursing interventions. Okay, so here we have the NSAIDs, and the NSAIDs I want to we have in NCLEX. They are not going to ask you who belongs to COX-1 or COX-2. These COX-1 and 2 are enzymes that are coming from the are going to, and enzymes that are going to act into a substance, into the phospholipase, and after the phospholipase are going to be the arachidonic acid, and arachidonic acid is going to be affected by COX-1 or COX-2. COX-1 is mostly all the NSAIDs, but I want you to just to pay attention on these. COX-1 are mostly all the NSAIDs, and those are the ones who has more side effects. COX-2, that is going to be the celecoxib, that is high yield for NCLEX. Celecoxib is the Celebrex, that is having less side effects. Okay, so here we have some table here. We have pain 1, 2, 3, Tylenol. All right, so that is very hepatotoxic. Okay, so Tylenol is is not an NSAID, but is giving between pain 1 to 3. Okay, so remember, Tylenol is more hepatotoxic than the rest and than the NSAIDs. Remember, Tylenol is not an NSAID. Tylenol is going to be more hepatotoxic than the NSAIDs. Okay, so you can start telling me, if you have toxic levels of Tylenol, you cannot take more than 3,000 milligrams, right? What are the signs and symptoms? Okay, so we will see in the next few slides. So pain 4 to 6, we're going to have this combination of opioids and NSAIDs. We have, for example, the oxycodone. We have aspirin, acetaminophen, caffeine is the Excedrin, and the aspirin and oxycodone is the Percodan. All right, pain 7 to 10, morphine and hydromorphone. Okay, so dilute is 7 times stronger than the morphine, the hydromorphone. Okay, so so here another thing that I want just to remark is I was telling you that the COX-1 that has more side effects than COX-2, right? So celecoxib, that is the Celebrex, and celecoxib is COX-2, and COX-1 is the enzyme that is going to be inhibited by the rest of the majority of the NSAIDs. COX-2 preserve the gastric mucosa. So that is one of the advantages of COX-2 of the Celebrex. Celebrex is mostly used for anti-inflammatory, but they are not going to make the mucus decrease in thickness. So that's why it's going to preserve the gastric mucosa. All right, so let's keep going. Aspirin, the 4 to 7 days, right? So that's what we was talking about, the plaquetary aggregation. Plaquetary aggregation. Aspirin has the property to inhibit the plaquetary aggregation for about 7 days. 7 days. So that's why we will do the mini pill for in cases of risk or increased risk for strokes or for thrombus. All right. So aspirin should be given as a first medication if you suspect of myocardial infarction. So that means that you will make the myocardial infarction stop or not happen. Actually, no. Myocardial infarction and aspirin. So you take aspirin in the scenario in case the myocardial infarction progress, your heart stop, so that can produce clots. So, but if that happens, you are prepared with aspirin previously in order to prevent the formation of clots, okay? All right. All right, so that is about reduce the platelet aggregation, the aspirin, and we are going to talk about the one thing, increased risk for bleeding. We have the garlic, ginseng, ginkgo biloba, ginger, and you can add here the green tea. So everything is G here. There's other, not necessarily need to be G in order to interact with aspirin. No, it's just I put it together. So garlic, ginseng, ginger, ginkgo, and green tea. I didn't put it yet here, but green tea can lead into increased risk for bleeding, right? Or because that is going to increase the effect of the warfarin. If you give aspirin, the bleeding risk increase too. All right, so here we have the Rash syndrome, and the Rash syndrome can lead into coma. It's a life-threatening neurological problem. Don't give aspirin to children less than 16 years old. Worse, if they have 2-3 years old, don't try to give the aspirin to the kids because they are going to produce the Rash syndrome. And Rash syndrome can lead into coma, liver damage, that it can be irreversible. All right, so children with flu-like symptoms and aspirin, please don't give aspirin. Children with flu-like symptoms are going to, and with fever and like flu-like symptoms, don't give aspirin because they can lead into Rash syndrome. Okay, so aspirin decreases the effect of the ACE inhibitors, the diuretics, and probenecid. You already know what is probenecid. Probenecid is one of the medications of the gout, right? So aspirin decreases the effect of ACE inhibitors. We have the decreased effect of diuretics and the probenecid. Okay. All right, so we was talking about the signs and symptoms of salicylism, that means intoxication for aspirin. And in adults, we have the symptoms are going to be tinnitus. In children, it's different, and this is high yield again for NCLEX, please. So the difference between intoxication of children and in children is very common that happen because they can make a mistake as a candy and they can take it and have a toxic levels. Okay, so we have children, we have dizziness, hyperventilation, psychological disturbances. Misoprostol, this is not an NSAIDs, it's a prostaglandin analog. So what is doing the prostaglandin? Remember, one of the effects is to increase the mucus of the gastric acid, and that's what we are doing here. So we are preventing stomach ulcers. Meantime, you are talking NSAIDs. So they're taking uh, together misoprostol and NSAIDs when the NSAIDs is being taken for long periods of time. Okay, acetaminophen. We have. They are going to have. It's a no-opioid analgesic, not classified as NSAIDs. Okay, so it's equally effective as aspirin and ibuprofen. I guess it's kind of interesting to know, right? So similar to ibuprofen, so that's people want to, if you have, for example, pain, fever, I will say acetaminophen is the best. If you have pain, fever, or probably you have inflammation, the best in this case is going to be the ibuprofen. Why? Because acetaminophen do not have anti-inflammatory activity, do not have anti-inflammatory activity, the acetaminophen. The maximum dose, NCLEX, 3,000 milligrams per day. Signs and symptoms of toxic levels of acetaminophen, please, is very important. So what do you think could be the problem? Now, this is, I need to remark this very well. We start in the first 24 hours nauseous and vomiting, like aspirin, similar as aspirin. And they can lead at the end, as the same as aspirin, acetaminophen, into coma, okay, coma. But acetaminophen in between, they are going to have something that is very particular, that is pain in the right upper quadrant. Right upper quadrant pain. So that makes sense, right? Liver disease, hepatotoxicity. So acetaminophen are more hepatotoxic than the others NSAIDs, than the NSAIDs. So acetaminophen is going to give you pain in the right upper quadrant, and because hepatotoxicity, what else we expect? We are going to expect, listen, it can lead to hepatic necrosis, right? So what is telling you that? That is telling you that the hepatocytes are going to blow up, be destroyed, and they are going to release enzymes. These enzymes are going to increase the LFTs. In addition to that, the bilirubin that is coming from the destruction of the red blood cells on the spleen, they're coming to the liver. The liver cannot metabolize that bilirubin. So, and means that the liver cannot metabolize, means that they cannot put it in the bile. So the bilirubin start to elevate in blood and you start to have jaundice. Conclusion, acetaminophen, nauseous, vomiting in the first 24 hours, 2-3 days, then after it's coming liver problem with pain up the right upper quadrant, nauseous and vomiting are going to continue. We have dark urine. Why dark urine? Because the bilirubin is there. It's a high dose. It's so much bilirubin in blood that is going to come out through the urine. And the jaundice. So that is about. So at the end, we have massive hematuria, coma, and death of the patient. Okay, so antidote for acetaminophen is the acetylcysteine. Another NCLEX remark is acetylcysteine is bitter, so give it with some soda or similar in order to prevent the bitterness. Okay, so here we have the chondroitin that is part of NCLEX. This is not an NSAID, but the chondroitin, what it's doing is to regenerate some joints through the collagen synthesis. So that for some reason they are going to decrease the inflammation because of this formation of new collagen, and secondary of that, the pain is going to diminish. Okay, so Ray's syndrome, we already talked about that. So Ray's syndrome, if you have a kid with fever, okay, flu-like symptoms, influenza virus, for example, is very common, and having with less than 60 years old, and you give aspirin, pues, okay, so you will have Ray's syndrome problem. All right, so we have the anti-gout. And talking about anti-gout, I will say that this is a problem of the uric acid. What is uric acid? Please, I want you to remember this. Uric acid mostly are coming into the meats, okay? Meat. Somebody who eat a lot of meat or just meat, they are going to produce a lot of uric acid. So the gout is the accumulation of uric acid, and this gout, it could be for two reasons. One is for the diminish of the elimination of the uric acid, and the other one is by increasing the production of the production of the uric acid. So we need just to remember some few things about what can produce the increase of uric acid. And this, please, I want you to have a paper, and if you can write down this. So medications that you will be familiar, and I put it together, are going to be, number one, loop diuretics can produce increase of uric acid. So they can produce bouts of gout. Loop diuretics, thiazides. Remember the ethambutol and the pyrazinamide. We are going to add here alcohol. That is your nursing consideration of gout. These gout people who take alcohol have that tend to increase the production of uric acid. And this pain is going to last about 2 to 3 weeks, and then it's going away. So it's not permanent. It's recurrent. It can be about 2 weeks and then disappear, but in the long run, about 20, 30 years, the periods of the length of the pain is going to decrease, but it's going to be more intense, the pain. Okay, so in time, it's going to decrease. There are going to be small bouts of less time of days, but the intensity of the pain is going to be higher. So that is about the gout, the general considerations. If you have too much uric acid, where are going to accumulate this uric acid? They accumulate in the surrounding of the soft tissue around the joints. Eventually, they are going to affect the joints, and that can produce an excruciating pain. Okay, so this uric acid, the diagnosis of uric acid is going to be not the excretion of the uric acid in the urine, not the excretion of, they can be, why? Because if you have uric acid in the urine, because you have too much uric acid in the blood, filtered by the kidney, that is an indicator, but it's not diagnosis. Why? Because negative uric acid in the urine do not rule out that you can have gout. If you have the signs and symptoms, well, what is going to be the diagnosis? The diagnosis is going to be a sample of the areas where you're going to have the accumulation of uric acid. Where is the most common area for gout? That is going to happen in the big toe, in the big toe, in the big toe. So that is the most common. It can be in the shoulder, could be in the elbow, but the most common is going to be the big toe. Okay. All right. So let's keep going. The uric acid can produce too in the kidneys these stones, because uric acid can precipitate because of the increase of concentration of uric acid in the urine. So the urine, the water is going to be is not going to dissolve the uric acid. The uric acid start to get together and precipitate, producing crystals of uric acid. Tofu is the inflammatory process that you can see in the picture. Tophi is plural, so there are accumulation these wheatish, grayish substance that are accumulate in that area. That is uric acid. That is so they are going to accumulate so much they can even break the skin by tension and produce that pain. All right, so the anti-gout agents. Finally, we talk about this. And we have general measurements of anti-gout. So you're going to, first of all, gout, that is in the period of asymptomatic, so no signs and symptoms at that moment, they do not receive pain. They do not receive NSAIDs. Okay, NSAIDs have a very dramatic effect on the on gout. Now, for pain especially and inflammation. Now, from these three medications, what NCLEX they love to ask is always about colchicine. Always you will find one or two questions of colchicine. And colchicine is going to be used for acute gout that is actually can produce this. That is the first line of medication for gout. Okay, so probenecid is for chronic and allopurinol for chronic. Okay, so I just create one mnemonic here. You can create your own. P means pyrazinamide, L is loop, A, alcohol, and niacin. Niacin, yes, the niacin, the vitamin B3, can lead into increase of uric acid. Ethambutol, and one more thing that they didn't mention, first of all, is the thiazides, and that tumor lysis syndrome. So when you have antineoplasia, they are going to destroy cells, releasing the DNA, and the purines are going to be metabolized. That increase the levels of uric acid. All right, so one thing that we need to remember about anti-gout agents, the previous is assessment of the hydration of the patient. Obviously, the dehydration is going to play a role in the precipitation of the uric acid. If you are low in water in your body, the uric acid is going to be most likely precipitate and lead all the deposit, tophi, or the hyperuricemia and the hyperurenemia. Okay. All right, so anti-gout agents, we have patient education. What is the problem of all this situation? Is the diet, right? So the meats, especially meat, cheese, wine, they're going to, meat especially, they're going to have a lot of are going to produce a lot of uric acid. All right, so talking about hematopoietic drugs, we were seeing this in the when we was talking about cytokines. But let's go specific to hematopoietic drugs. We have the erythropoietic drugs, and the colony is for white cells, so we are not going to talk about that. The platelet is no white cells, so they are going to be, but this is hematopoietic drugs. Erythropoietic drugs are under this hematopoietic drugs, so we are going to talk about this only. Epoetin and darbepoetin. So this, please be careful of this. This is the darbepoetin is going to be long acting. Can you see the word is longer? Darbepoetin. Okay. All right. So that is going to give in anemia in patients with ESRD, that is the end stage renal disease. End stage renal disease. Because who produces the erythropoietin? The kidney. So if the kidney is not working, there is no production of red blood cells. Erythropoietin side effects are going to be hypertension, skin problems, rash, and pruritus. Okay, so erythropoietin is going to take effect in about 2 weeks to initiate the increase of the levels of red blood cells. Another NCLEX question. So there is a relation here that they can lead into risk for thrombosis. Risk for thrombosis, if you have too much red blood cells, they are going to aggregate, right? So there is, and if they have hemoglobin more than 10 for cancers, it's contraindicated the poietin alpha. And if there is more, is 11 or more for renal patients. So that is the two main contraindications that they have this erythropoietin, and the darbepoetin, easy to remember, is a long-acting. All right, so here we are going to talk about iron. Iron, we have two presentations, the ferrous sulfate and irodextran. Ferrous sulfate is PO, and irodextran is IV. Some nursing considerations about, in general, IV and oral we are going to see now. Constipation is one of the side effects. Dark stools. Always ask for, you're taking iron, the stools are going to be dark. Okay. One thing, another is the injection. The injection is going to can produce pain. Another thing is that the liquid, when it's in liquid presentation, they can stain the teeth. So in that case, we need to use a straw to avoid the staining. All right, so iron preparation, we have toxicity, orthostatic hypotension, orthostatic hypotension. So, and fatal anaphylaxis, that is the levels of toxicity. Antidote, that's deferoxamine, that is the first one, is the most common. The deferoxamine, you must know and remember this, please. Iron, we have here, we need to take an empty stomach, okay? With vitamin C, remember the iron, we need to take it with some acidity, some vitamin C, some orange juice, etc. Vitamin E, the opposite, is going to delay the uptake of the iron, So that means less absorption. Okay, so iron preparations in when you have an IV presentations, first of all, you need to be careful because need to be slow, it's not in bolus, it need to be a slow given an IV, a slow infusion, and they need to, the patient lay down for about 30 minutes after application because the side effect of this iron IV is the hypotension, orthostatic hypotension. So if you have 30 minutes laying down or recumbent the patient, that is going to minimize the risk for falls. Preparations here for iron, we have what part of the diet, we have beans and dry food. Beans, dry food, high GI, and avoid eggs with iron, okay? They can actually inhibit the absorption of iron. The egg itself have iron, but if you take iron supplement plus egg, that is going to not allow the absorption of the iron. Some side effects of the iron IV is could be nauseous, vomiting, and they can lead into preparation of the patient, pre-medication, and it's going to be about half an hour, 45 minutes to make full effect of the diphenhydramine, that is the Benadryl, is an antihistaminic, or acetaminophen in order to diminish the pain of the infusion. The C-tract, the C-tract is injection is an intramuscular, prevent the staining of the skin. Okay. We have contraindications of iron is the hemolytic anemia. So if you, the hemolytic anemia means destruction of the red blood cells. And that means if you give iron, the iron doesn't have any place to go because the red blood cells have been destroyed. So what happens is going to reach high levels of toxicity very fast. Folic acid. Folic acid is the vitamin B9. And that is promote the cell division. Cell division is mostly used for prevent malformations as a spina bifida, as a prenatal vitamin supplement. And the most common cause of folic acid is the malabsorption. So that means that you absorb in the intestine no fats, and the fats are going to just go into diarrhea. Folic acid. So here we have, you need to start at least 1 month before pregnancy, and need to be continuous through that. And the last thing is the vitamin B12 is usually deep for injection, intramuscular. Do not mix with other meds. So this vitamin 12, patients, they need, we talk in class, the intrinsic factor. If they don't have it because they're old or they have pernicious anemia that they don't produce, in both cases, gastric acid, so the absorption of vitamin B12 be diminished. So deep injection, so mostly they can be given in the deltoid muscle. Don't mix with other meds because they can precipitate. Okay, so I think that is about for the review today. I want to thank you everyone who was present, and I will, if there's any question, please just let me know. I'm going to unmute everybody. Alicia, so I'm not going to say last names, but Soli.
No questions.
No
David?
question.
Joanna,
No question, Dr. G.
Soli, Dalina.
Yes, questions.
Okay, David, thank you so much for coming too. Okay, all right, so thank you. If any question, please just let me know. I'm going to post it in the next few minutes, this video. Muchas gracias. I will see you next time.
Thank you.
Thank you.